I'm yet to localize for any of the neuro-ophthalmology. So this talk of localization would cover three aspects of the examination: ocular motility and nystagmus. And if time permitting, we look at visual fields and how we can localize the lesion, looking at the visual fields. So let's look at the first scenario: a patient with abduction limitation. As to what would you do to localize a lesion? Now, if it's isolated, then localization can be either to the nerve, that is the sixth nerve, muscle, which is fibrosis or entrapment of medial rectus muscle, or neuromuscular junction. Myasthenia is a great mimic. It can produce any sort of oculomotor disturbance to begin with. So what would you do if you see a patient with abduction limitation? Number one, look at the other eye. Number two, look at other cranial nerves. And number three, look at the fundus scapula. So let me show you some examples. So this is a young man, and if you see, patient has a left esotropia, and you'll find that there would be an abduction limitation when the patient looks to the left. As I said, look at the other eye. You'll find some sort of nystagmus, a little cyclic nystagmus. If you look at the upper eyelid of the left eye, the affected eye, you'll find that there is a gold vein implant. Patient had, apart from abduction limitation, a seventh nerve palsy which had caused leg ophthalmos and which has been treated by doing a gold vein implant. So the question is, where would you localize this lesion? See, abduction limitation with leg ophthalmos, and the other eye which has some nystagmus. The demonstration of the left facial nerve, which is little. So if you have an abduction limitation with a seventh nerve, there are possibilities. Either the lesion can be at the CP angle, that's where the sixth and seventh nerve are together, or in the brainstem. Now this patient had a CP angle lesion. So what would happen if the patient had a lesion in the brainstem? This is how the ocular motility would appear. Again, if you see, it's not very clear here, but the right eye upper eyelid had a gold vein implant. Patient had right facial nerve palsy, and now patient is trying to look to the right. And if you see, there is a gaze palsy. Right eye is not abducting, left eye is not abducting. This is the difference between a brainstem lesion and a CP angle lesion. Brainstem lesion, because abducent nerve nucleus is a gaze center, would have a gaze palsy with seventh nerve, while a CP angle lesion would have a sixth nerve palsy with the seventh nerve in the same eye, and nystagmus in the other eye. One more example of an abduction deficit: a young man with sudden onset diplopia. And when he is looking straight, he actually has a right esotropia because he's fixating with the left eye. But when the ocular motility is being tested, you will see that there is a left limitation of the left abduction. Now patient is looking to the left, and now he's following the target and is looking to the right, and you will find that even the adduction in the affected eye is not complete. Abduction is completely limited. Now you'll find when the patient looks up, the elevation in the affected eye is down, and depression also is down. So what this patient actually had is abduction limitation with partial third nerve. No adduction or partial adduction, partial elevation, partial depression. Sixth nerve with third nerve, you would localize lesion to cavernous sinus. A little more a lesion in the cavernous sinus, which was a little more pronounced, it will produce like this. A complete third nerve. You see a complete ptosis of the right side, and you see that adduction limitation in the right eye. So basically a right third palsy. With, if you see that the right abduction is not complete and is slow. So third nerve with the sixth nerve, you would localize it again to cavernous sinus. So that's about the abduction limitation. Let's look at some aspects of third nerve palsy. If you see a patient with third nerve palsy, three important aspects that you look at. One, first, most important, look at the pupil. If the pupil is involved, it's a compressive lesion of occipital third nerve. Look at the fourth nerve, third and fourth nerve together, it's likely to be a midbrain lesion. And a recovered third nerve palsy, look at the eyelid very carefully, as in this patient. See, patient has, patient has a mild ptosis of the left eye because patient had left third nerve palsy. Now look at the left upper eyelid. The other oculomotility is reasonably sort of well recovered. We find that elevation deficit is there. And when the patient looks down, you will see that there is a lid lag. So this is an example of aberrant regeneration of third nerve, which is the third important point that you look at in third nerve, because aberrant regeneration is almost never seen in ischemic third nerve palsy. So if you see this in a recovered third nerve palsy, again it's an indication of neuroimaging. You localize the lesion to fascicle, a compressive lesion. This is a young man who had an acute onset of oculomotility like this. Patient is trying to look to the right, left, up, down, and you will find that the eyes are not moving at all. But what you see is there is a hopping of the eyelid. And as you are examining the motility, you see that there is a little ptosis. So if you see a patient who has a complete movement restriction, it could be nerve muscle, neuromuscular junction, or supranuclear centers. Nerve is less likely because such an extensive lesion causing all abolition of function of all nerves is less likely. This patient with differentials were maybe an acute onset of myasthenia gravis, which can be seen in children, or a supranuclear center problem, or a variant of Miller syndrome. The patient turned out to have myasthenia gravis. From oculomotility, let's look at some example of nystagmus. This is an example of a gaze-evoked nystagmus. Any nystagmus, if people who are writing exam, if you're asked as to where would you localize a lesion in nystagmus, you say cerebellum, 80% of the time you'll be right. So here is a patient who has a torsional nystagmus, which is gaze-evoked. It comes about even before the end of the gaze. And the second important point to note here in the nystagmus is when the patient looks down, the eye movement is actually vertical. It's a down-beating nystagmus. This patient had Arnold-Chiari malformation, which was responsible for this nystagmus. So now, let me ask you, where would you localize the lesion in this nystagmus, which you see on your right-hand side? As I said, localization of nystagmus, if you say cerebellum, you're right 80% of the time. So where would you localize it here? Cerebellum? No. This is in the other 20%. You see this patient had a pendular nystagmus. So if the patient has a pendular nystagmus, you look at fovea and optic nerve carefully. This patient has albinism. Albinism is associated foveal hyperplasia, which was responsible for this pendular nystagmus. If you see a patient with pendular nystagmus, also look at the palate. This patient can have what is known as oculopalatal tremor or myoclonus. If patient has pendular nystagmus with, if you look at the palate, it is also pulsating. So if patient has a palatal tremor with pendular nystagmus, you localize the lesion to brainstem. And this is, I think, my last slide. Patient looking straight, patient converging. If patient converges, this is how the eyes look like when the patient looks straight. And when the patient is converging, a close-up look shows a little bit of nystagmus. So what this patient had was convergence retraction nystagmus. You localize the lesion to dorsal midbrain. Now, this is my last slide. Again, a case of nystagmus. So if you see a patient with nystagmus, you localize the lesion to cerebellum. This is a left beating nystagmus when the patient is looking straight. And you're not really doing anything, patient is looking straight and you see that there is a left beating nystagmus, and then nystagmus stops, and then suddenly it starts beating to the other side. And this cycle keeps repeating. This is called periodic alternating nystagmus, and the localization of the lesion is to cerebellum. So in other words, oculomotility is an important marker of brain activity, especially activity in the brainstem and cerebellum, or occasionally along the course of nerve, which will be in the orbit or cavernous sinus. So any oculomotility problem, you need to evaluate the other cranial nerves to localize the lesion. Thank you so much.